Good morning, everybody. Again, I'm Bob's wife. Again. Over and over again. And Bob is having his second eye operated on today for cataracts. So I am such a poor substitute, believe me, and I keep saying to Bob, please don't schedule these things on a Friday. This is not my deal. I'm great with the mic. Not great on it. But today we have a really, really special program. First of all, anybody who may have brought their cell phones, please be kind enough to turn those off. That does sort of interrupt the mood. We have a good turnout today, wonderful. I've talked to a couple of people privately who said, you know, I may not come to current events on Friday. It sounds very depressing. And I said, well, think about it. There are parts of life that are not totally joyful. But the more we know and the more we're educated about it, and the more we're grounded in the subject, the less anxiety-ridden perhaps we are. So thank you all for coming. But today we have the son of Fran Winzelberg, one of our residents, and she, being a very proud mother, has been whispering in our ears for a while that I've got a son who needs to be up here in front. So we welcome Dr. Gary Winzelberg. A little bit about Gary Winzelberg. He is a doctor, of course, and division chair of Palliative Care and Geriatric Medicine at the Medical Center in Massachusetts, and a visiting clinical associate professor of medicine. Prior to his current position, Dr. Winzelberg was a faculty member at the University of North Carolina School of Medicine, where he served as founding director of the fellowship program and medical director of the Carroll Woods Retirement Community. Welcome, Dr. Winzelberg. Thank you.
Can you all hear me? Okay, terrific. So I am here to visit with my mother, but I must admit that a big part of the attraction is to have the opportunity to have the Reuben sandwich at your deli, hopefully for lunch. So thank you for the kind introduction and the opportunity to speak. I am going to focus my comments on what to me has been a revolution in healthcare over the last 30 years that you may or may not be aware of, but I think it's important to have some familiarity, and it's the field of palliative care. I also can, in the question section, get more into geriatrics as a specialty, or if you invite me back, can have a separate discussion about that. But to me, the opportunity to witness and participate in the development of a new specialty of medicine and its impact has been really quite a privilege. And I think, as I thought about framing this discussion, I think there's the cliche, which is true, that there are only two certainties in life: taxes and death. And so, to me, though, what I want to focus on is the living part prior to death, because the death part is a certainty for us. The mortality rate is still 100% for all of us. That hasn't changed. But it's how are we going to live before that? And really, if you think about the changes in the last 100 years, some of you who have witnessed, 100 years ago, much more of dying was acute. Infection, accidents, and actually COVID, I think, really as a society, because of all of the horror of deaths, I think has brought it to the forefront even more. But the chronic conditions that for many of us lead to illness for months, even years, is important to think about, and what's our relationship to technology, and how do we kind of grapple with our wishes and living well with serious illness. So I'm going to start with a little bit of history to kind of frame the issue, then talk about how this field of palliative care developed, and a little bit of what the components are, because some of you may well, even today, or certainly in the future, benefit from palliative care services as part of your care and your health care. So, to me, it's a good story in terms of medical advancement and progress, really starting, I would say, from the 1950s with the development of intensive care units, with the development of the iron lung for polio, which ended up getting transformed into what nowadays are mechanical ventilators. In 1960, there was an article in the Journal of the American Medical Association publishing about CPR. And amazingly, it got published based on 20 patients, the results of 20 patients. Nowadays, there would not be a study of that importance if there weren't hundreds, if not thousands. But they quoted at that time a 70% survival rate from CPR, which is much more than what the reality is. But that led to, in the 1960s, CPR becoming basically universal procedure. In some ways, a good thing. Anyone can go out to the Red Cross and learn CPR, but in terms of, and this predates my medical career, but in the 1960s, no one was allowed to die in the hospital without a CPR attempt. And my understanding is there was a lot of trauma and suffering related to that. And so people were starting to question, what are the consequences of some of these procedures or technologies? I think a few other things, just to kind of put in context, dialysis became a universal covered procedure in 1972. So Medicare was in 1965. Dialysis is actually its own universal health program. And then there started to be attempts at correction. So the living will was created in the early 1970s, and I imagine some of you, if not many of you, may have a living will. I think the thought was that we need to be able to protect ourselves during times where we may not be able to speak for ourselves, and we can talk about, it's still an ongoing debate as to how effective or frankly ineffective living wills are in helping people receive the care they want towards the end of their life. But that was through cases like Karen Ann Quinlan in 1975 that you might remember, or Nancy Cruzan, who went her case to the Supreme Court in the 1980s. It codified the right of individuals to try to express their preferences. And the hospital where I trained in Boston, and this was in 1976, published a paper about the concept of DNR, or do not resuscitate. So again, from the 1960s even into the 1970s, CPR was a universal procedure. But in 1976, the proposal was, you know what? This isn't something that's helpful to all people. We need to give individuals the chance to make different decisions for themselves. And by 1991, in terms of living wills, there is now, and I imagine you all who have had to be hospitalized have experienced this, the Patient Self-Determination Act by Congress in 1991 requires hospitals receiving federal funds to ask patients when they're admitted if they have any advance directive, and if so, to be able to include it in their chart, or if they would like assistance, to be able to assist them. So that takes us into the early 90s, and I think there was a thought that these living wills could be helpful. I think another interesting thing is Though Medicare was created in 1965, the Medicare hospice benefit was not started until 1984. So really 20 years after the creation of Medicare. So, Medicare has really always been more of a sickness program than a health promotion program. And even this access to hospice care, it took about 20 years. And so for me, I came of age in medicine in the early 1990s, and there was another landmark study of seriously ill patients in hospitals, and this was also published in JAMA, and there were thousands of patients in this study, all in the hospital, all seriously ill. These were reputable hospitals: Duke, UCLA, Beth Israel Hospital in Boston, Case Western in Ohio, and the first part of the study tried to understand what people's experiences were. So these were individuals with lung cancer, heart disease, lung disease, liver disease, all who were estimated to have about a 50% risk of dying over the next 6 months. And the study was really powerful because what they learned was these were individuals that were very much symptomatic. Their families said that many of them had moderate to severe pain, moderate to severe shortness of breath as they were in the hospital. And also, talking about code status or DNR, many of the physicians who were caring for these patients did not know their patients' preferences regarding this specific decision, this procedure in the hospital. And so the investigators of this study were shocked and I think disappointed, and so they said, let's design an intervention to try to fix this, because this is a problem that so many patients who are sick and at risk of dying in the hospital have unmet needs when it comes to symptoms. Their doctors aren't talking with them. So let's try to fix this. Their intervention was to have a nurse who would review the chart every day and provide information to the physicians about what the patient wanted when it came to their code status, what their preferences were. And so the hope was that that would change things. What do you all think about, a nurse talking to a doctor, at least in the 1990s, about, patient preferences? Do you think it made a difference? I see a few head nods yes, but many more were no. And so it was a negative study. It had no impact. And this was millions of dollars. It wasn't a government study. It was a private foundation. But this was a well-meaning intervention. It made no difference in the experiences of patients in the hospital. And so this really, I think, shook the medical world, but also started to have an impact culturally in terms of beyond healthcare, thinking, in the public about, what care was like in the hospital, care was like towards the end of life, because the services at the time, hospice, and we can talk about that, but that is for patients who are identified as dying, and then living wills, advanced directives, none of the mechanisms that existed at the time, services, living wills, made a difference for people that were in the hospital. About a third of these individuals who died in the hospital spent significant amount of time in the intensive care unit. So I think this was a really challenging experience for them. We can talk about costs as well. That was something that was certainly considered. And so through this, and this was published in 1994, what led to, what evolved from this was this field called palliative care. And so initially, palliative care was created to address these needs in the hospital of patients. And so let me sort of step back and talk a little bit about what palliative care is. So It is a medical specialty, but it also now is available as a specialty for nurses, for social workers, for chaplains, and it is appropriate for individuals of any age. So there are colleagues of mine in pediatrics who provide palliative care. I'm a geriatrician, so it spans the lifespan. And so when I talk to patients and families about the work I do in palliative care, it comes in 3 different areas. One is symptom management, so any physical, emotional, mental health symptoms that impact a person's daily activities and quality of life for someone living with a serious illness. So that's one area. The second area is supporting individuals and their loved ones in coping with serious illness and the stresses related to that, whether or not they're in the hospital. The third is trying to ensure that a person's care is guided by their values and priorities. And I do that, and in palliative care, we do that in partnership with the individual, the patient, their family, but also their other doctors. And so this is appropriate at any stage of illness, and I'll talk a little bit more about that, at any age, any stage of illness. And one way of thinking about it is an extra layer of support, because medical care, if anything, has only become year by year more complex. There are more and more technologies. So I talked about, mechanical ventilation in the iron lung. Well, now there's regular oxygen, there's high flow oxygen, there's, some of you may use CPAP at night for sleep apnea, there's BiPAP in the hospital. There are all of these interventions, lots of advancements, but also the risk of extending someone's life in a way that may be associated with symptoms, stresses that make it difficult for them to, live the way they would want, live in a way that they would define as quality. So initially, palliative care was started in hospitals to respond to this study and the results. And so amazingly, now essentially, virtually every hospital, certainly every large hospital, Mayo Clinic for sure, has a palliative care program of one size or another. A little bit less so in terms of smaller hospitals. But so the field started in hospitals, but then over time, the recognition was when individuals are in the hospital sick, it can be challenging to navigate their symptoms, their coping needs, their decisions. Why don't we try to move that upstream? And so one of the landmark studies in palliative care was in 2010. So now we're more in the common era. And this was individuals with lung cancer. This was a study published in the New England Journal of Medicine, about 300 patients at Massachusetts General Hospital. And there was a randomized trial. Half of the patients received usual care, and half of the patients started with monthly palliative care visits very close to the time of diagnosis. And this was all patients with metastatic cancer. And so what this study showed was the patients who received palliative care had less depression, had higher quality of life by sort of validated scientific surveys. But the reason that this study, I think, was in a prominent journal was that those who received palliative care lived almost 4 months longer than the individuals who didn't receive palliative care. And so I think the study wasn't developed to try to figure that out, but there are theories about that, which include, when we are communicating with someone who has a serious illness, we are developing a connection with them, we're getting to know what makes them tick, what matters most to them, then they may be less likely towards the end of their life to continue to receive treatments that end up having higher risks than benefits. So that, these are individuals, it wasn't as if the people who received palliative care said, no, I don't want any treatment. The treatment up front was pretty similar between the two groups, but as people got worse, there was a change in terms of earlier involvement of hospice, less use of the intensive care unit, interventions that, as people get sicker, again, have diminishing returns. And so, actually, at this point, the latest guideline in the oncology community, based on now not just that one trial at Massachusetts General Hospital, but now over 10 randomized trials, are that every individual with advanced cancer should be offered palliative care services within about 8 weeks of diagnosis. Completely impossible. Because if you think about it, there are now yearly, so palliative care became hospice, it's actually called hospice and palliative medicine, became a medical specialty in the late 2000s, and by 2012, fellowship training is now required to become board certified, and it's a one-year fellowship beyond someone's core residency training. The country is producing not much more than 300 palliative care physicians a year. So again, and there's the story is even worse with geriatrics. So I don't want to depress you all on a Friday morning. But if you think about, again, the immense needs, not just with cancer, but name the chronic conditions that people live with, it's a paucity. I mean, there are more interventional cardiologists that are produced in our country every year than palliative care. I looked this up recently. Mayo, down the street, has a hospice and palliative medicine fellowship. One fellow is trained every year. So again, where the fellowship that Sally Ann mentioned that I helped found has grown now from 2 to 4 over a 5-year period. Still very small, certainly for the needs of North Carolina. But it's an aspirational goal in terms of even oncology to be able to offer these services. And I think the other piece is that with fields like palliative care, but also with geriatrics, we realize that there will never be enough of us to provide one-on-one care to all that need it. And so part of our role is through disseminating skills and knowledge to our colleagues. So, for example, at Leahy, where I am now, I was on a call yesterday where we're going to be training surgeons or resident surgeons, training surgeons, about how to talk about code status, about in the hospital, whether someone wants to be full code or have a DNR order, because it's a core procedure. Communication is a core procedure that gets short shrift in medical training still. Oncology has embraced palliative care. Geriatrics has embraced palliative care. It's a required part of geriatric medicine training to meet the needs of older adults. And the involvement of palliative care is growing in other medical specialties, kidney disease, heart disease, lung disease, in terms of these areas of symptom management, coping support, and what I would call goal concordant care, trying to understand the goals of someone in terms of their treatment, in terms of how they define quality of life, and trying to support them in having that life. So let me just pause for a moment. So I think those are the key sort of concepts, a little bit of the historical background when it comes to palliative care. And so I think, I don't know all of the specifics. I know there is a palliative care service at Mayo. I've not done my research in terms, and I know not all of you, I imagine, receive your care at Mayo, but I think it is not something that physicians necessarily think of, because unfortunately there is still a linkage. So, I mentioned hospice. I mentioned that our specialty is called hospice and palliative medicine. The two are distinct services, distinct fields, and I think for physicians, for my colleagues, sometimes they misunderstand what I do as hospice care, and so I need to educate them. I think the other challenge is that physicians, because they take care of people who are sick or people who may ultimately die, they think that they do palliative care, but they don't necessarily have any of the training or skills. And that also applies to geriatric medicine. So, it is a field that has been emerging over the last 10 years, but really the context was 30 years ago. And so for me, to witness from when I was a medical student where there were none of people like me in the hospital, to now having the privilege and the opportunity to, both in the hospital and in the clinic setting, sit with individuals with various conditions and challenges and work to support their quality of life, work to understand what matters to them most. Because I think, I'll leave this perhaps as my last comment and would love some discussion, is that living wills themselves have been shown to have very limited, if any, impact on someone's experience, care at the end of life. Especially if it lays fallow in a safe deposit box. But even more so if it's not tied to communication that someone has with loved ones, or I would say, if sometimes even more importantly, with a clinician, a physician, a nurse practitioner, so that we can work with someone to help shape what their care plan looks like. And so, again, I think, palliative care for any age, but certainly as people age and are living with more chronic illnesses, has an important role in providing symptom support, coping support, and then decision-making support so that people can live as well as possible.
Thank you very much. Wow, that's a lot to unwrap. So we're going to open it up now. We're at about the halfway point in our meeting. Open it up for questions from all of you. Sarah, hold on one second. We do have the microphones. For those of you who are new to this meeting, we have two people, one on either side, who will bring a microphone around because we are, in fact, a hearing challenged audience. Let's start with that. And these microphones help a great deal. When you get the microphone, if you hold it yourself, please hold it about here. Here doesn't work, here doesn't work, here doesn't work. It really has, and the top of it, okay? Sarah?
Thank you. Is palliative care covered by Medicare, and is it covered by just regular insurance that one is not yet at Medicare?
Yep, so thank you so much for that question. So the answer, did everyone hear the question? Okay, so the question is yes and what I mean by that is yes, Medicare, private insurance covers palliative care. And so for someone receiving palliative care, it is the same as going to see a cardiologist, going to see another type of specialist. The and part, which is a broader question that actually affects both palliative care and geriatrics, is for the time, and I would say the expertise required, there is a gap between what Medicare covers and what the actual sort of cost of the service is. And so for palliative care, to survive and even thrive, it depends on often hospitals or health systems to support, I don't like the word subsidy, but to support the work of palliative care because of the time that's required is not fully covered by Medicare. And so that's a real challenge for the field because Medicare is much more geared towards covering procedures that involve technology rather than procedures that require someone's mind. But yes, it is absolutely a covered service when it comes to going to the medical office or if someone is seen in the hospital for a consultation.
Carolee, up here, Charlie.
Okay.
You get a workout with
We've got both sides.
Yeah. Yeah.
Thank you. As a Mayo patient, I inquired about geriatrics and was told that there is no specialty of geriatrics at Mayo, and it seems like that flowed, that you started out as a geriatric doctor.
Yep.
And then that kind of flowed into the palliative care. And I just wondered if you would comment about that. I was very disappointed.
Yeah. So.
Excuse me, what they said was every doctor should be able to treat every age group.
Yep. So, well, and I want to be a little politic, maybe, and I realize that about Mayo, and that's a little bit of why I shifted a little bit more towards palliative care. But I think the perspective that I have is, number one, yes. I mean, there are family physicians, there are general internists, there are cardiologists who, because of their practice, have committed themselves to developing what I would describe as primary geriatric medicine skills or foundational geriatric medicine skills. But it is fundamentally different seeing a geriatrician and being part of a geriatric medicine practice in terms of having the board certification and the expertise when it comes to geriatric medicine issues. And so, I think, to me, again, it's the challenge of, as I noted, not everyone who is, over 80 or over 90, there aren't enough geriatricians, in the country to sort of meet that need. So that's a reality. But, I would love for Mayo to have even a small geriatric medicine practice, both in terms of meeting some degree of primary care needs of older adults in this community, but also to provide leadership for teaching, for dissemination of new knowledge related to geriatrics. And so, where I am at Leahy, which is outside of Boston, right now I am the only card-carrying geriatrician. So I don't advertise that very much because on the North Shore of Massachusetts, there are many older adults, but over the next couple of years, I am going to endeavor to start a clinic because, again, there are distinct skill sets that not every family physician or general internist has.
Interesting. Are some of those skill sets perhaps involve a degree of psychology? Is this what you're sort of saying?
So,
Because you
well,
refer to the mind.
Well, I would say in terms of geriatrics, to me, some of the added expertise involves medication management. So again, the recognition that there are just fundamental changes as people get into their 80s and 90s in terms of a medication that might have agreed with them in their 50s and 60s. Their brain is different, their bodies are different, their kidneys are different, and then anytime someone takes more than one medication, whether it's prescribed or over the counter, there are risks of interactions. And so I'm not a pharmacist. I certainly worked with pharmacists, and again, part of what geriatrics does often is a team-based approach, which is, again, similar to palliative care, but, in terms of mitigating or preventing falls, I think, in terms of medication management, I think another piece that geriatrics, again, develops expertise in is healthy aging, including brain health. So, again, I wish the treatments that we have for dementia are terrible. And you all may have been, aware of in the news the latest treatment that essentially, has gone, Medicare is not going to pay for it, I think appropriately so, because of its, risk benefit, but that's another area. So I wouldn't say that there are formal skills in counseling, but to me it's the work that we do in assessing and supporting people's cognition, brain function, physical function, that is, again, I'm not saying that we have that knowledge and we hide it from everyone. We try to share it with our colleagues, but it is a distinct skill set than someone in general practice has.
Yes, over here. Fran, the mother.
What we have? There's someone behind.
Okay. There was a time when I, at least, and maybe other people, thought of hospice as a place that you go to.
Yep.
Now we're seeing that hospice seems to be a great deal more than just a place you go to. I wonder if you would paint a picture for us of what hospice really is and what the criteria are for determining who is a hospice patient.
Thank you for that question.
He's a doctor.
All the questions have been excellent. So I think hospice care as a benefit. So someone asked me about coverage of palliative care. Hospice is its own insurance benefit. And so it actually, in some ways, is more robust than what palliative care provides. And so the way that I think about hospice is a service for someone with a serious illness who has decided to discontinue disease-directed treatments and focus exclusively on their comfort and dignity for however many days they have remaining. And so cancer is the prototypic condition that I think people think of with hospice, but it can be heart failure, it can be dementia, and so most hospice care, and I think it's probably going to be different at Vickers, but outside of Vickers, most hospice care is provided in people's homes. And it requires someone to have loved ones to help support them at home because hospice is not able to provide anything close to 24/7 care. It may offer a nurse that comes in once or a few times a week to check in on someone. It offers a 24/7 number to be able to talk to a nurse if there are worries or concerns, but it doesn't have, an aide that's in the home but for a few hours, a few times a week. There is the component of hospice that I think Mayo has an inpatient facility and can talk more about what that looks like. It's, as everything with Medicare, it's complex regulatory-wise. But so to me, you may have heard about hospice having a 6-month prognosis. That is a little bit of it's not quite accurate, meaning what we as physicians need to do when we're considering hospice for someone is to stipulate that if their primary disease that qualifies them for hospice, if that follows its natural course, the person's prognosis is 6 months or less. but we have to validate that essentially every 90 or 60 days. So I've had, in my career, one patient, actually at Carol Woods, which is also a CCRC, who received hospice for over a year because she was living with dementia, was living in the health center at Carol Woods, and each time the certification was required, there were changes in her condition that allowed me to say, with full sincerity, that I still expected her disease to be 6 months or less. So I think the prognosis piece trips up a lot of physicians and also patients, but because of that, ultimately, too many patients receive hospice services for too little of a period of time. And so what I share is that hospice is focused on helping each day be the best day possible, independent of the number of days. And it can be provided in people's homes, it can be provided in a health center setting, it can be provided in a dedicated hospice facility. So perhaps too long of an answer, but it's a kind of a complex service.
Is it Carol?
I was disappointed to hear you say that the right to die doesn't really help the booklets, because Florida has spent a lot of money trying to get those right. I've done 2 workshops for people on filling them out, and I just wonder what you think is what is the right way?
Yeah. So, and this is, I think in the palliative care world, there's a prominent physician who recently drummed up a lot of controversy because he said, we have spent millions and millions of dollars developing, different tools, different documents, trying to study them, and if you look at it, it doesn't matter. Not everyone believes that in terms of living wills. I think what I would share is not that people shouldn't complete living wills, but that what matters is a couple of things. One is having a trusted person to be in the role of a surrogate decision maker or healthcare proxy, healthcare power of attorney. I don't know what the term is. Because, that is, it is rare, truly rare, that document, whatever it looks like, is something that I'm going to be able to say, oh, now I know what this person wants. It's often pretty general. The exact medical situation may not apply. And so what really helps me, and I think my colleagues, is someone who knows that person, has hopefully talked with that patient in the past, and is able to say, yeah, I have a sense of what this person would want, what their values are. And so the living will can perhaps be the launching point to have that conversation, but really what matters is the conversation. So having that trusted person and then having that conversation about what matters. And if someone has strong preferences, then sometimes, again, this happened at Carol Woods a lot, which is a DNR order is different than a living will. So I think it's important, there are some, and there were many residents who I cared for who thought they were one and the same. And so, the living will is a sort of an aspirational document, but it needs to be translated into specific decisions. And so I don't honestly know, I apologize for not looking this up. There's another tool, which again, some people question, but in Massachusetts it's called the MOLST, in Oregon it's called the POLST, Physician Orders for Life-Sustaining Treatment. And so it is actually more specific about someone's preferences regarding certain treatments, like artificial hydration and nutrition, dialysis, mechanical ventilation. And so that can, for people who have strong preferences, and many people may not, that can be a tool that may have more specificity than a living will.
I think the Florida one, if nothing else, the Florida one does help you have that conversation with your loved one or
Yep.
whoever you would designate, and it talks about a lot of those
Yep.
things.
So, and thank you for saying that. The last thing I want to do is to have you all, burn your living wills. I'm not suggesting that, but I am suggesting, don't let them, gather dust in a safe deposit box or in a drawer somewhere. They're meant to be kind of living, breathing documents. And so, for example, and I hate, when I lived in North Carolina, I hated the state living will because it was all legalese, so that's another piece. You don't need, please don't, if you have, no one should pay a lawyer for these documents. They are, don't require a lawyer. And so, there are versions, 5 Wishes, for example, is a document that the state documents are often too much in legal terms. 5 Wishes, for example, is something that can be pulled off the web that again helps people who are willing to think a little bit deeper in terms of what does quality mean for me? What am I willing to go through? Another question actually related to living wills, and then I'll stop, is there was a fascinating study in the 1980s. These were individuals receiving dialysis, and they asked these individuals, if you develop dementia, and they all had living wills, what should we do with the living will? And about a third said, follow what I have in my living will completely, no matter what my family says. A third of the people said, ignore the living will, do what my family wants. And a third said, it kind of depends on the situation. So, in North Carolina, at least, in the living will that the state produces, there's actually a box that gives people the choice to say, let my family decide ultimately, don't let my family decide. Again, it gets into a little bit of a mousetrap, but I think, that's the piece too, which is in the end, even if someone has a living will, it's often general, and in the end, families, especially vociferous families, have a big impact. So that matters, if someone lacks the ability to speak for themselves, who are going to be the people there interacting with the doctors about, your care?
Fran, the mother.
I had wanted to say that can you hear me?
Yes?
That I think that people have a tendency when, for example, when I was in the wellness center the first time, I had just broken my wrist. And I don't know why that put me into such a trauma, because I had never had anything happen to me before. And I was there for quite a while. And until my son took care of me. And what he did was, he sort of demanded that I be seen as an individual, not as just one of many people there. So I think you had meetings, didn't you, once a month or something like that, Gary? Where you would have the social worker come in and say what they were doing for me. How many people were involved in this?
Well, I don't want to violate any HIPAA requirements here, but I think what I would sort of jump on that question is, there is a lot of ageism out there.
Yeah.
Which was going to be my other sort of main theme, which is to say, there are a lot of assumptions whether it's in the hospital or, in a health center, and it's not limited to Vickers at all. The care that my mother received here was phenomenal, it was excellent. But when people see an older adult, they make assumptions about, their memory is poor, or that they, because they've fallen, they're not going to be able to live independently again. And I remember at Carroll Woods there was a joke, but it probably, some people probably believed it, that if someone fell 3 times, they would have to move to assisted living. And so I think, what is important is, and this is where there is intersections between geriatrics and palliative care, is, as my mother said, seeing the patient as a person. And trying to get a sense of what their baseline is, what their hopes are, and they may not be achievable, but to not make just sort of blanket assumptions. And so, certainly, from your experience, I was pleased, you did all of the hard work after that fall, but I think, supporting you, and I imagine, many others are receiving this care here, again, to identify what their goals are, and in your case, it was, getting back to your apartment, and to trying to have a care plan that supports that, and not make assumptions that just because someone is 90 or 95 or 100, that means X, Y, Z, because in geriatrics, we really recognize that chronologic age is different than someone's functional age. So I have certainly, in even my current work, there are a lot of people who are in their 60s who are older than you may be in your 70s, 80s, and even 90s. And I think that's a role that we have in geriatrics to try to help address the ageism that's out there.
Question, one back there? That's Joan, I think. Joan Thomas? Well, okay, we have the microphone here. Wait one second. Give him time to get back to you, Joan, and we'll take Nancy.
Oh, I just wanted to ask if you're in the hospital as a patient, can you request this care?
Yeah, so thank you for asking that. These are all spot-on questions. So, yes, I think, and generally at this point in 2022, physicians will say yes. I think, as with any, and hospitals can be a little bit different, but again, physicians have to okay the consultation. So, someone in the hospital can say, I want to see a cardiologist. And the physician might say, I don't think you need that. I think, they would do that at their own peril in terms of, a patient directly asking for that. So I think, nowadays, if someone asks for a palliative care consult or a family asks for it, often it will be granted. Sometimes, physicians might say, oh, I don't think you need that, you're not dying. And the response is, you don't understand palliative care. Palliative care is about helping people sort of live well, and it's not about dying. So yes, you can absolutely request one. But I think the other piece that I'll just quickly say is, though, again, we work in partnership with our colleagues. So for example, in the clinic, I am primarily working with patients who have cancer. I am not doing it in a vacuum. So I am, if I'm starting a new medication, I'm talking with their oncologist. So, I want to make sure that if I'm involved in someone's care, their oncologist is sort of okay with that, because I don't want to be doing one thing here and the oncologist is going to be doing another thing there. That's only going to potentially harm the patient.
Okay, Joan.
I just recently went through everything you're talking about, and I think the most important thing to me was listening to all that had been done and being able to say goodbye. I just felt very comfortable with everybody that worked with us, my husband, palliative care, hospice. And it just made everybody in the family feel so much better.
Well, I appreciate you sharing that, and I am. It's so important that you received and hopefully are continuing to receive that kind of support, because again, for every person is different, but there are needs, and the healthcare system often benefits from having the additional support from palliative care. The healthcare system, individuals, families. Thank you.
Jeannie.
I lived in England back in the 80s, and of course they had national health, trying to save as much money as possible. But I had a friend who was diagnosed with a fatal cancer condition. And what they did was they did an operation which purportedly was a simple operation which nullified all of the pain receptors. And this man lived happily for 6 months. And then as he got sicker and sicker, he just got tired. But he never had any serious kind of discomfort of any sort. And he had a very rewarding last 9 months. Is that procedure available in the United States, and is it offered generally?
So, don't know the specifics, but I would say a few things in response. I think one is there is a concern, certainly that many patients have who I meet, that the end of their lives are going to be full of pain. And I think what I would share with confidence is that does not have to be the case. Pain is something, whether it's related to cancer, other conditions, that, there is lots of options out there for management that's effective. And so sometimes it's interventions that are done. There are various nerve blocks, ablations that are done. But I think the other piece that I would share is, again, depending on the pain, depending on the person, there are a big sort of toolbox that I use for helping to manage pain in serious illness so that people can, live as fully as possible. And so that is something that, I want to be able to communicate that, that's, I think, another difference between palliative care sometimes and, what I see, in some of my colleagues. I'm just thinking about a patient who I met yesterday who has a cancer where for the last few weeks she's just been on the smallest dose of essentially morphine, and she needs a little bit more, but the doctors who have been treating her aren't comfortable with even increasing it a little bit more because they don't have the training or skills to do that. And so by seeing me, I'm very confident, and she's gonna start treatment on Monday. I'm very confident that we can get her pain under better control.
Okay, just 1 second. Joan Grander? Have you read a book called Being Mortal?
Yes.
Yes. I just wanted to make a comment and do you think that's a good thing for all of us to read?
Oh my goodness. So Being Mortal, Atul Gawande, who is, actually he's now working for the US government, but he is a surgeon. That book has done more to promote the fields of geriatrics and palliative care than perhaps any of the studies that I referenced, and so could not recommend it more highly.
I certainly recommend that everybody here get that book and read it. It's wonderful food for thought. and it really is terrific.
Thank you.
Thank
It
you.
is very good. Did we have a question over, Nancy?
Sounds like communication is really extremely important between you and your patients, and for all of us.
Yes.
Absolutely. I think that communication piece, which again, it's changing slowly in medical school. Again, you know, you all, when I make Marcus Welby references now to medical students, they have no idea what I'm talking about. But right, I think there was a thought for a while that you either had bedside manner, so to speak, or you didn't. And I think what we've learned over the last, again, as part of this revolution, is that communication skills are skills. They can be taught, right? No one is born a surgeon. No one is born an expert in communication in terms of navigating some of these, you know, really challenging decisions. And so that's the privilege that I have in terms of the fellowship that I created, the learners that I work with, in terms of thinking about, you know, even talking about hospice as a procedure. Because a lot of people, when that word is mentioned, get really scared about what that means and what their future is. So, yes, thank you for emphasizing that. I think that's, to me, you know, one of the most hopeful things, again, in terms of how palliative care has impacted medical care in this country. And one of those downstream effects is that it's becoming more and more of an expectation that physicians are going to learn these skills as a core part of their training. It still won't, you know, it will not obviate the need for palliative care, it will not obviate the need for geriatrics, but it will help.
So we're down to the wire on time. If there's a burning question, please raise your hand so we can see you. You have a burning question? Sarah, okay?
First of all,
Hold on. Microphone.
can't be loud voice, I just assumed. First of all, I'll put a copy of Being Mortal in the library if anybody is interested in reading it. I have a couple of extra copies. Second question, you said something about Medicare is changing its philosophy on dementia, and then you moved on to another subject. Can you pick that quickly back up?
And I would say, and I'm happy, I know, you know, I have visited your wonderful library. I mean, one of the things that's been amazing over the last 10 years is that the popular societal interest in serious illness and, by extension, end-of-life care just seems to be insatiable. So Paul Kalanithi wrote a book that was a Pulitzer finalist. He was a neurosurgeon diagnosed with stage 4 lung cancer towards the end of his training, and actually happened to be an English major at Stanford. Incredible book. There are so many books that have been sort of published. I'm happy to share with Sally Ann, you know, some of the ones that I had read. It helped sort of sustain me. So no, the specific, and I'm now forgetting the name, but it's been, you know, on the front page of the New York Times, quite controversial. There was FDA approval for a new brain plaque reducing medication for Alzheimer's within about the last year, but it created quite an uproar out of concern for the influence of the drug company, the lack of quality of the study. Again, I'm not a particular expert in this. The cost of it, some of the risks in terms of brain bleeding, and again, understandably, individuals with dementia or, you know, people who love people who have dementia are desperate for treatments. And so what ended up happening was, though FDA approved it, several medical centers like Cleveland Clinic said, and I don't know what Mayo said they weren't going to provide it. And then what Medicare decided was that they would only, I believe this is true, that they will only cover it if it's for someone participating in a clinical trial. Because the conclusion was that the medicine isn't ready for prime time in terms of treatment. And, in terms of sort of offering it, it's an IV medication, and so I believe that there are more trials that are being done, and I could easily Google the name, but that was the issue with that particular medication.
Any other burning questions? Well, I just want to make one comment, and something that has concerned me all my life, for whatever reason, is one of the greatest isms out there is, in fact, ageism. And I think you would all agree with me that suddenly one day we all wake up. It seems sudden to me, and we're old. We're defined as old. I mean, it starts subtly when people start calling you ma'am and you're about 45 or 50, and you think, what the hell is going on? But in fact, for a long time in our minds, we think like we thought many years ago, and we don't fully recognize that other people see us differently. So ageism is really something that I care about and have always cared about. I just think it's a very unfortunate prejudice, and we are all now in that category. But that is simply leading up to my final thought, which is to thank Dr. Gary for, his mother says he doesn't even like to be called doctor, that he likes to be called Gary. I think we can sort of see why based on his personality. He treats people as superior to himself, which is a tremendous characteristic, especially for a doctor. We all should do that. But I've decided to have a happy medium and call you Dr. Gary instead of Dr. Winzelberg. I think you have a calling, and I think there are very few people on the planet who have actual callings, whatever that means. It's a somewhat ethereal term, but this to me is a calling. That's why there are not hundreds of young men and women out there going into this field. Number one, they have a prejudice about us to begin with. When we advertise for dining help in our facility here, I understand from our dining staff that one of the considerations of people looking on the internet or wherever, one of their reactions might be, do I really want to work in an old folks home? And the day we move in here, we are defined as living in an old folks home. We're not. We're living in an apartment, and we came here to live initially. The good news is we're able to stay here to die. I mean, there is a conveyor belt that's going to take us, well, hopefully somewhere in a great beyond. But in any event, you have a calling, and your compassion is palpable, and we thank you. If you have a personal question,